talk for us. It's nice to see kind of a different crowd from what we usually get out to these talks for Marathon Club. A lot more ultra runners in the crowd and some people I don't know for sure, so that's great. I just have a little bit of a bio. Dr. Galbraith hasn't done a talk for us before, so for those of you who haven't met him, I just want to give you a bit of a background. He was born in Lethbridge, Alberta, and raised in Seattle. While an undergrad in the States, he met his wife Kelly, who's from southern Alberta as well. He attended medical school in Phoenix, Arizona, and then completed family medicine residency in South Bend, is that Indiana? Yeah. Following residency, he completed a sports medicine fellowship at the University of Notre Dame. And over the last few years, he has been team physician for 5 universities and colleges. Currently, he's team physician for the WHL Lethbridge Hurricanes, Lethbridge College, and Raymond High School. He's worked closely with university-level track athletes and long-distance runners. I know a few of you in the crowd, at least. He and his family moved back to Alberta in 2010, and he's been married for 13 years with 3 children. His favorite pastimes include swimming with his family, snow skiing, hiking, mountain biking, and following Notre Dame football, and triathlon, right?
And
Talk to some triathlon. So let's give him a hand.
Can everyone hear me okay? Is that fine? I really don't want to wear a mic, so if I don't have to.
If not, move up if you want.
That's right, this whole front row is totally open. I have a couple goals. I really hope that I don't put anybody to sleep, so I honestly want this to kind of be interactive. I don't want to just sit and preach, because in reality, you guys can probably teach me a lot about this topic, and maybe I can fill in some gaps here and there. So I'll see if I can swing this around just a little bit. But please, I really want this to be pretty interactive, and yeah. You know, in medicine, when you give like talks in medicine, you always have to have a disclaimer like, I'm a pharmaceutical rep or sponsor for so-and-so company. My main disclaimer is, I have a lot of fast twitch fibers. I'm not much of a long distance runner, but I have run the Moonlight, and I survived the hill. That was great, so that was fun. Maybe just for my benefit, it's great to see such a great turnout. Who here has never run an ultra before? Fantastic. That's what I was really hoping for, so maybe someone will learn something. Who here has never run a marathon? Who here has never run a half marathon? See, my hand will still be up? Okay. That's great. Who here, anybody run more than 10 ultras? Anyone run more than 20 ultras? That's a lot of ultras, so I'll stop there. So, yeah, that's fantastic. So what I'm hoping to do is kind of tap into your knowledge as well. So obviously, since I'm not a long distance runner, I've learned a lot from you guys with running, from patients in my office, and then also just a lot of time in journals, a lot of time reading. So I'll just kind of get on. I have a lot of pictures, just because I'm a visual learner, and maybe that'll keep you awake a little bit. One of my main points here is I'm hoping that we can actually share some ideas, and I can say, hey, here's what I've seen work with some patients, and you guys can say, well, this has maybe worked for me, and you guys can maybe learn from each other. And if we're lucky, you guys can learn a few random things along the way as well. I won't bore you to death about really common things, but I think it's important to talk about some of the really common things you see in ultra running. So, blisters. Has anybody gone running long distance and never had a blister? Wow, that's pretty good. That's pretty good. Does anybody here always get a blister if they run long distance? Yeah. So maybe we can tap into each other and kind of get some tips about so what causes blisters? Any thoughts there? Dirt. Friction, right? Friction, dirt. And am I standing? And I'm actually not that tall, but am I blocking this?
No,
It's a great. See, it can be short occasionally. So I mean, basically, blisters come down to friction. Usually, something's rubbing up against the skin, right? Maybe it's a pebble, maybe it's some dirt, maybe it's your skin, your shoe, and just mile after mile, ultra after ultra, that definitely kind of add up on it. And so then you're going to have that break in that superficial skin layer, the epidermis. I couldn't imagine running on that. That looks horrible. That was, yeah. Yeah, he's like, well, that's just another day. Another day is an ultra, right? Does that, so I kind of want to pick your brain. You know, with a lot of runners that I've taken care of, they have kind of their little stepwise things about how they prevent blisters. What do you guys do? What do you use? use? I'm just curious to kind of open it up. Glide? Yeah, we'll talk about Glide, you bet. Vaseline?
Duct tape. Duct tape.
I love duct tape. So pretty much anything, right? It doesn't matter what it is, just throw it on your body and see if it helps. So I love duct tape. I even have it on my rearview mirror in my car. So I'm a big fan. And so we'll talk about some of the different brand things that you can use to help prevent between Glide and duct tape and second skin, all kinds of things like that. But ultimately, just some of the real basics, you want to make sure your shoes fit pretty well. Obviously, running stores like that are fantastic for fitting, right? Fantastic. You want to make sure you have a good, well-fit shoe. You don't have too much motion, too much play, but at the same time, you want a nice, snug fit. How often do you guys change socks when you're running like a long race? Does anybody? What's that?
Never.
Anybody change frequently?
I'm just afraid that if I take my shoes off, I'd never get them back on.
Because it's funny, that's all over the map. I've never seen any studies for that. I have some long distance runners, they swear by changing socks every 2 hours. They're really rigid. And some will change them maybe halfway through a run if they get wet. So I think what that means to me is it's really variable, right? And so I think you have to kind of experiment with what works with you. And you have to try it out beforehand instead of just waiting until race day and saying, hey, what's going to happen when I run 100 kilometers? So, what kind of socks do you guys use?
5 toes.
Anyone else?
Gotta love them. They're the best. I don't think blisters anymore.
Yeah.
What do you use? 5 toes.
So lots of different socks, right? So obviously running stores will have fantastic socks. I would not recommend cotton. So as you know, just generally cotton for clothing, not a good idea. I know. And just think you've got like 50 more K to go. Isn't that like awesome? And I'm just kicking it in the medical tent, ready with my like blade to open you up. I won't. Just briefly about blisters. Again, you'll get differences of opinion. Usually, if it's a relatively small blister, I just kind of leave it alone and I cover it or try to treat it. I only will open really large blisters, generally speaking. So many of you have heard of the Badwater Ultra down in Southern California. This is just a sweet picture I found online. Those are some pretty rough looking toes if you look pretty close at that. But I'm sure after the lost sole, you have some pretty nice looking feet too. So we mentioned duct tape. Some people just put duct tape straight on the skin. Some people use moleskin first, then duct tape over top. There's a lot of different types of concoctions. And again, really it's what kind of works for you. So I don't have stock in any of these companies. So I know Runner Soul carries Second Skin. I'm not sure about the Spiroflex, but there's different brands. Second Skin is very common to help both prevent blisters and also treat as well. So that's a common, very popular product as well. And again, you put that on those friction areas where you're prone to have a blister. Does anyone ever do the donut pads or use moleskin much? If you kind of notice the tape, look at kind of the orientation of the tape. What's maybe unique about that? Maybe that's kind of a dumb question, but what I like about how they've done the tape job on the left of that heel, that Achilles, is it's actually vertical. Why would that make a difference?
Oh, the one on the heel.
Exactly. And it's something really simple, but actually can make a really huge difference over time. It's not going to get caught, it's not going to roll in your shoe or your sock. So, chafing, same idea as blisters, right? So, this is kind of a hard picture. Can anyone see where that's at? So, it's kind of like blowing up in your face. So, it's a women's bra, jogging bra, you can see right there. I won't ask who's had this. So a lot of the things with chafing are very similar to blisters. There's lots of powders, right? There's a lot of different Glide type things, Vaseline that you can use. Same idea. And you want, again, breathable clothes. I just put down Cool Max. And then we'll go into actually, we'll show a few of these things. Has anyone ever had chafing here in the armpits?
Yeah. Oh, yeah.
All of them.
Oh. Horrible. Yeah, not fun. The only time I actually had that was backpacking once. I grew up in Seattle. We went backpacking in the Olympic Peninsula where they have a rainforest, and it rained a lot. So much that our trail actually got flooded out. We had to hike back 17 miles in one day. And I was about 15, and my whole body was chafed. And I remember my thighs and my arms. I was not a happy camper. So, but I wouldn't like to run, another 50K on that. That wouldn't be very fun. Anyone use any of these products? Just curious?
Yep.
Anyone swear by any of these products? Again, it'll be all over the board. So, pretty simple, for the most part, relatively inexpensive. You won't break the bank on any of these. Gold Bond's been around for years and years. I know Body Glide, what I'm calling Body Glide is a very, very popular one. Vaseline's been around since the dinosaurs. Vaseline's used for everything. So, very simple. This kind of looks like a dirty, perverted picture. I promise it's not. So if you look really close, I was showing my wife this just the other night. She's like, "Do you really have to include that picture? That's kind of disturbing." So, but if you look really close,
The disturbing part is the fact that he's smiling.
she's like, "This is awesome. This is
Like he
great."
should be crying, really.
Oh, that looks horrible. That'd take a lot of Body Glide to put out, right? So what, maybe in this situation, the idea of what would kind of set him up, maybe for getting some of this chafing and then actually.
I didn't see a disclaimer.
What's that?
I didn't see a disclaimer before the picture came.
Should you put a disclaimer?
Yeah.
Hair?
No.
Wow.
So potentially hair.
Shorts, inside seam shorts.
And that's key. And sometimes I think with your clothes, test out your clothes before you run a really long distance in them. Those seams can make a big difference. You may not notice it in 5K or 10K, but once you get to half marathon distances, those seams, whether it's in the armpit, the axilla, the inner groin, and so I don't know in his situation, but that very well could have been a huge factor. So just kind of know your seams where they land. Should I just leave the picture?
He's got no,
Has anyone ever used A&D ointment? So A&D ointment was, at least for doctors, is usually used as like for baby rashes, creams, and also burns. But once someone actually has chafing, so it's used more for acute treatment for chafing, maybe not so much for prevention. A lot of long distance runners swear by A&D once you get some chafing. It can be fantastic. These are actually, I think, 4 tips that I ran across. I can't remember the resource on this specific one. I thought these were great, and I'll be honest, I can't coach them probably word for word. So I'm sorry I didn't put like quotes around these, but there's my disclaimer, but I know I didn't want to put that. So, but I really like that. Never ignore a small little irritation in your foot. But again, that small little irritation, the first 2, 3, 5K, what's that going to develop into when you're on your 100th mile, right? Or your 50K? A little pebble or tiny crease can go a long way. It'll come back to haunt you tenfold. That third point says practice taping, lubing, lancing, coating, all of those things again before race day. Do all of that in your training. The last thing you want is this surprise, what's going to happen with this new Body Glide I've never used before. Oh, I've never tried this powder, let's see what happens. Or maybe I've never tried these shorts. Let's see what's going to happen here. And I like that it says create foot problems. In other words, I think it's okay to experiment a little bit with different products, socks, shoes, etc., just to see what's going to create a problem with you, again, before race day. Ultimately, you can do all of this stuff, and can you still have problems on race day? Of course, right? In fact, you probably will. But the goal is, can you try to minimize it? Can you try to minimize the problems you'll have in race day so you can finish your race and hopefully not die? So, like me in the pool. Who here has ever had a stress fracture? Anybody ever had a stress fracture? Stress fracture is actually pretty common. There's probably a few other people in this room that have had one that maybe didn't know they had one and they just chalked it up to tendinitis. One common myth that I hear about, just a normal fracture, what we call a cold fracture, and a stress fracture. I have people probably every week come and say, Doc, I don't think I broke my finger. I can live it just fine. I shattered my finger, not this one, different one. I shattered my finger. I had no problem moving it. Didn't feel very good. People can shatter bones, have open bones, and they can still move it. Stress fracture. My general take home with that is, and I'll probably say this a couple times, if you're not responding to your treatment, to rest and anti-inflammatories, to physio, to chiropractor, massage, like you think you should, maybe it's a good idea to get it checked out by a doctor just to make sure, especially a doctor who maybe is familiar with stress fractures, just to make sure that you don't have something. I don't know in this picture, can you see that stress fracture very well, the big fat circle? So that kind of medical jargon, that's your second toe. It's actually in your midfoot. They call it your second metatarsal. So they've had a stress fracture, but over time, it's kind of like God's duct tape. You put this callus that wraps around the bone that takes weeks and weeks and weeks before you actually see it. So if someone comes in with an acute stress fracture, and I think, gosh, maybe they have a stress fracture of the foot, I'll take an x-ray. And then many docs say, well, your x-ray looks fine, you don't have a stress fracture. But it might take 4, 5, 6 weeks before that shows up. So I think that's important as a runner to know that just because you've had an x-ray does not guarantee you have not had a stress fracture. Well, I guess maybe I'll drill you with a medical question. Let's say your x-ray is normal, you're really scared that you have maybe a stress fracture. Any idea what's the next best test or study to look for it? See, I can teach someone. This is great. I can actually teach someone. So, usually in the States, where I train, MRI. Fantastic. You get an MRI tomorrow. Perfect. Wonderful. Maybe 2 days if you're pushing it.
Yeah.
6 months.
So, Lethbridge 6 months, Calgary 9. So, we count our blessings, right?
Yeah.
So because of that, I don't do MRIs acute for stress fracture. I'll do a bone scan. Downside, bone scan has quite a bit of radiation where MRI doesn't. But bone scan, you can get results we'll usually be able to get one within 3 to 7 days. And that's really important information for me. And for a runner, especially if you have a big run coming up, I think that's good info. I just saw a Canadian junior national level skier with a stress fracture of her back. And again, she'd had this for months and months and months. Normal family doctor, chiropractor, physio, acupuncture, just not getting better. And my suspicion was high enough that I said, I think we need to do a bone scan. And of course, it lit up at this one segment. So, any idea where you can get stress fractures at? No cheating. Of course, you can get it in the foot. Anywhere. There you go. So most people that bear weight on their legs, it's most likely lower extremity. Less likely upper extremity. Although you can get stress fractures in ribs with golfers, some repetitive swings and weird injuries. You can get stress fractures, some unusual carpal, so that's a little different. But so usually lower extremity. So where in the lower extremity maybe would be some high risk areas? Any thoughts? Shins? Shins are big, so shin or the tibia. Ankles?
Hips.
Hips. Hips actually can be a scary one, yeah. I'll show you a few pictures just so you're aware of it. Oh, who cares about stress? See, I'm pretty ignorant when it comes to technology. I know how to do about 3 things in life: medicine, play trombone, and roof a house. That's about it. I feel really well rounded. So, who cares? Where did that come from? Who cares about stress fractures? Why would, let's say me as a physician, why would I worry about that?
Because it would get worse.
Pardon?
It could get worse.
It could get worse instead of better, right? And there's even a few really key stress fractures that can develop into an occult fracture that may need surgery. That's why, those are some reasons I really worry about a stress fracture. Not just, it's kind of a nuisance, I'll better stay out here for a little bit. So a few areas, this is a special stress fracture you see in the the base of the 5th metatarsal. You see the little crack over here. I'm not very tall, but bigger. This one is kind of classic for having poor blood supply. And you need blood supply to an injury to heal, right? And so if you can't get good blood supply, that bone will not heal well. They call this a Jones fracture, named after an orthopedic surgeon. Guessing his last name is Jones. And so it's very common, I should say it's not uncommon, for people to get actual screw knee surgery for this fracture. So when someone comes to me and is like, Doc, I'm having a lot of pain on the outside of my foot, I think, well, you could have tendonitis and tendons out there. Sure, that's very common, but this is high on my list of someone that's ramping up their mileage or running really long distances. Kind of an unusual looking picture. This is an MRI. It's kind of fuzzy, but you basically cut straight down, what they call a coronal cut, straight down the front, and you're looking at their pelvis and their hips. And the white on the side, that's your femur. And the big arrow goes up to the stress fracture of the hip. Those are horrible stress fractures. And there's two main types of stress fractures in the hip. One is a little more likely to heal with time, and you won't need as much time on crutches. The other one has a high risk for surgery, and we'll probably need a nail for it. So how do I treat hip pain in a long-distance runner? Maybe a little bit different than the average physician if I know someone's running long distances or they're ramping up their mileage. I may not just say, oh, you've got bursitis. Suck it up, princess, take some Advil, right? I still might say that, but and then they clinch it. Any idea what part of the body this is? Shit, man, you guys are amazing. So, they always teach us, kind of in medical school and residency, that shin splints are usually pretty broad of an area, and a stress fracture is more of a narrow area. Here's an MRI of the shin that shows you the stress fracture actually is a little more broad in this specific person than you might expect. That's actually a little more broad than you usually would see with a stress fracture. But notice that white area that all those fancy red arrows are pointing to, that's swelling in your bone. That's edema. And that's kind of like you take your tibia and over time you bend it like a paperclip, keep bending it, keep bending it, keep bending it, and all of a sudden at a microscopic level it starts cracking and cracking and cracking and it gets inflamed. So that's a stress reaction, and eventually there's the point it kind of cracks a little more on the macroscopic level, hence the stress fracture. So shin splints, it's not always shin splints, just be aware, potentially it could be something a little worse. I thought I'd share just some interesting cases of patients that I've seen. Well, I don't know, you can tell me if they're interesting, but has anyone had blood in their ear before? I guess I probably shouldn't ask that in public, sorry.
Oh, sure.
I'm sorry. So here's an example of a 45-year-old. I'll just move on.
Okay, so
Before I can remove my foot from there. So, this is a runner. After they ran a long distance, a few hours later, I think it was later that evening, they noticed when I went to the bathroom, all of a sudden there was a lot of dark red in the toilet. Understandably, a little bit concerned. So, any idea what this is called? Oh, well, there you go. It's even in red. So they call this gross hematuria, not because it's disgusting, because you can actually see the blood with your eye. Versus microscopic hematuria, you can't see it, but if the doctor does a urine test, you can it'll show up. Oh, there's some trace red blood cells here. Any idea what causes this?
Microtears in bladder.
Pardon?
Microtears in bladder.
So there's a few different theories, and that's one of them. You can imagine that repetitive pounding, mile after mile, your bladder, especially when it's empty, just kind of flapping. And you get this trauma, and it gets inflamed, and it can have some tiny cuts even in it that can actually lead to some bleeding inside the bladder. There's a few different names. They actually first found this in marchers in the United States when they would march long distance with the big combat boots, big backpacks, mile after mile. So they call this marcher hemoglobinuria. Also, foot strike hemolysis is kind of a common name up here. And then they also think with the foot strike that maybe that repetitive pounding of the feet can actually damage red blood cells that are then circulated in the body and then excreted out in the urine too. So, exercise-related hematuria. There you go. Maybe you learned something here, something different. When would I care about that? Or when should you really do? What's that?
When you start seeing the blood.
When you see, most people flip out when they see blood in the toilet.
Yeah.
No matter where it's coming from, they're usually not happy. The good thing about this exercise-related hematuria is it's usually not serious. It's usually not a big deal. It usually runs its course within a matter of 2-3 days. It's usually not going to cause anemia, although in a small percentage it can. We usually just give them fluids, tell them to rest, hold off on anti-inflammatory medicines, and then things will cure up usually fine. But if it doesn't clear up usually in 2 or 3 days, then I start being worried, and I might want to check some blood tests looking at your kidney function, and actually checking some more blood studies and urine studies as well. So I think that's good to know as a runner. After you do a long distance, whether it's marathon, ultra distances, if you're having blood in your urine, you wouldn't freak out quite yet. You can still be nervous, that's okay. Make sure you drink a lot of fluids, rest, hold off on the Advil, and then if it doesn't get better, then I would maybe get on the phone and see if you can see within 2 or 3 days. Any questions about this? I think that was my last slide there. Okay. Any questions about blood in the urine and hematuria?
Is there any way to prevent it that you would suggest?
I don't know of any. So some runners will talk about having enough hydration so that their bladder isn't floppy. I don't know if there's a lot of like research behind that. Some runners will say they feel better with a bladder that's partially full, but whether or not that actually makes a difference, I don't know. I don't think I had any other questions, so I'll move on. I'll share another interesting case. This is, I was in my fellowship at this time. We had this young lady, she's actually kind of a novice runner, and it was kind of odd. So we were in Indiana, it was in the middle of the summer, but the start time of the race was like 7:30, so pretty early. I think it was around 75 degrees, so not that hot outside. And she was only running a 5K. And about halfway through her 5K, she was found by one of the medical folks, and she was just literally staggering, completely disoriented. She looked like she was completely intoxicated. And so they threw her in a golf cart, brought her to the medical tent, and she came off the medical tent, and she was just kind of doing this. And from a physician's perspective, I'm like, really? Come on, lady. Serious? You don't need to act. There's no one else in here. I mean, you've been running for like 13 minutes. Like, come on. A little melodramatic. It's kind of like my 12-year-old. So they decided to check their blood pressure. Fine, great, wonderful blood pressure. Looks fantastic. They checked her oral temperature and then her rectal. I'm like, oh, I don't think she's supposed to be that warm. And so, yeah, she was almost 107 degrees Fahrenheit, which is very hot. Not good. Then we realized we have an emergency on our hands. I don't think she's baking it anymore. We should actually pay attention to her and take care of the patient. So what's this called? Any idea? What's going on with her? I hear some people muttering. No one's willing to just like put their neck out. So this is heat stroke. So heat stroke. We'll talk a little bit about that. Do you know if you've seen cases of heat stroke? Maybe Aaron, any idea if you've seen cases of heat stroke there at law school?
Lots. Yeah.
I would imagine. I would think down the river,
It gets hot.
It can get pretty hot, toasty summers, right? So, generally, so maybe the question is, so there's something called heat stroke. Sometimes you hear about grandma. She was in her apartment in Chicago. The air conditioning went out. It's been like 110 degrees in Chicago, horrible humidity. And then she's found dead or something in the apartment. That's not a very nice story. But so that's a type of heat stroke is what I'm getting at. That's a type of heat stroke. But what's different is, was grandma exerting herself? No. She was just making eggs or crocheting. There's nothing wrong with that. But exertional heat stroke is different. So exertional is you actually get heat stroke while you're exercising. That's a totally different mechanism in the body than just simple environmental exposure alone. So what's different than heat stroke compared to heat exhaustion? You'll hear like heat cramps, heat exhaustion, heat stroke. There's a lot of weird terms thrown out. I could dedicate a whole topic to those, but
Heat exhaustion is not a medical emergency.
exactly, yeah. I'll give you a hint, both are hot. So heat exhaustion is not a medical emergency where this is. Now, if a patient presented to you, or maybe you saw another runner, any idea how they would look different to you? They both feel like garbage. They're kind of like nauseous, have a headache, feel lightheaded, tired. I just feel like garbage running. The big thing is, so sweating, you'll hear about that. Sometimes you get hot enough you don't sweat. You see that in some people. That's something that classically we'll see in textbooks, but in reality, this lady was sweating quite a bit. The lady was almost 107 degrees. So I wouldn't hang your hat on that. The big thing with heat stroke is someone is confused. in medicine they say they have altered mental status. And so they're just a few cards short of the deck. There's something that's a little bit off in this patient. And so this lady that was kind of, looked like she was intoxicated, she could not throw a sentence together. She was off her rocker. And so that's, I think, really important to know, even if you're a runner, because you can be running with your friend, or you can maybe even be a medical tent, and I can be treating a patient. You can say, hey, they're not themselves. I know this person, I've run with them, I've seen them at races. They're off. And that's actually really, really helpful for me as a physician to know that. Because I may not know kind of what, I think this is maybe their normal baseline, I don't know. So that's exertional heat stroke. Very, very important to know that. Believe it or not, the most important treatment for exertional heat stroke, cool them down as fast as you can. Fast, fast, fast. So what we usually do, if you have access to it, you literally throw them in that. And their temperature will plummet within a matter of 10 to 20 minutes, and you will save their life. Because heat stroke, if not treated, is fatal. It will kill them. So if you don't have an ice bath, this is the best way to go. It's just what they call cold water immersion. If you don't have this, then we'll try to find as many ice packs as possible. We usually put it in their axilla, you can put it on their chest, in their groin, put a cool, damp wash rag over their forehead. Try to remove as much clothing reasonably as possible. Remove their shoes, their socks if they're wearing gloves or whatever. What's maybe before I move on, it's interesting. I think it's great if you want to call 911, but I wouldn't do that yet. My treatment initially would be this: stabilize the patient, because 911, the ambulance is going to come up. They're going to sweep them away on a stretcher, put in some IVs, start some fluid, and it's going to take them a while to get to the ER. Then the ER is going to just give them cold fluids, but what they really need to cool their temperature isn't just cold fluids. It's actually immersing their entire body. This will save their life. If you wait in the ER, you actually will probably do more harm than good. The trick is trying to convince the ER doctor that. So it's interesting. This is actually that patient I was talking about. There's a lady sitting right there in the white shirt. Notice, can you see, well, right here we have a rectal probe temperature. Kind of disgusting. The most accurate way to check someone's temperature is through a rectal probe or a rectal thermometer. There's been lots and lots of studies I won't go into, but like the tympanic membrane, the ear thermometers, those that you scan your forehead, nowhere near as accurate when it comes to exertional heat stroke. There's been lots and lots of studies that say, oh, she could show up 101 degrees and then 105 with the rectal probe, and that's a pretty big difference. So what do you see in this picture that is indicative of how we cooled her down? So a kiddie pool. So kiddie pool, that actually was filled with ice and it's since melted. The fan, which is huge. Yep, so we actually had IV bags where we gave her some cool saline. We didn't want to freeze her to death. We kept her in there a little too long. I think we kept her in about 25 minutes. Her temperature dropped from about 107 down to 101, and then we pulled her out, and then it went all the way down to 95.7. For some reason, she was shivering. I'm not sure why. But it was interesting. Her mental status completely cleared within a matter of 10 minutes. Like, you'd actually carry on a conversation with this lady. It was phenomenal. Very amazing. So while she was in it, we had these cool damp wash rags, etc. So now, maybe contrast it a little bit with this picture. So now let's say we have a 25-year-old, they're confused, they're lethargic, they're staggering on the running course. This one I'm making up. But now she's collapsed. Any idea what's going on with that? And I might even put in here collapsed and very confused, really lethargic, not responding extremely well. That's not a good sign. So, what's that?
She's unconscious, you're saying?
So she's borderline unconscious. She's not responding very well. So, any idea what other problems could be going on with this? Pardon? It's out of fuel. So there's a deficiency with your fuel, right? Okay.
Dehydration.
Dehydration, yeah. In fact, these are probably the two most common things you will see in this situation when someone's collapsed down. they've lost they just haven't had enough fuel, right? They haven't had enough calories and haven't had enough fuel or fluids. That's actually the most common thing. Diabetes, that was actually a really important comment. So much sugar could be in the tank, and they could be unresponsive and having a hypoglycemic coma. That's not a good thing to have. Any other thoughts? We know it could be heat stroke. Yeah? Hyponatremia. Yeah, and we'll talk about that. So what's hyponatremia?
Too much water.
Too much water. Yeah. And that so much water that actually their sodium is low, so their salt levels are. So, well, we'll talk about just a few other things for this. So think of this exact same athlete. I listed a number of different things there that potentially could be causing what's going on with her. So the first thing, exertional heat stroke. Man, you guys are perfect at that. You can recognize exertional heat stroke with a rectal probe like anybody. The next one, exercise-associated collapse, is probably one of the most common. Again, fatigue, dehydration. There's something called postural hypotension. Have you ever seen the end of a run? They sprint to the end of the finish line, they finish, and all of a sudden their legs give out on them. They're down, right? Any idea what causes that?
Drama queen.
That's great. So as you're running, your leg muscles, for example, are pumps. They're pumping the blood. They're helping to circulate your blood. Now all of a sudden you stop. You have so much blood flow to your legs. And with gravity, all of a sudden you're down because you're not getting quite enough blood flow to your brain. And so the treatment for postural hypotension is usually just let them lie down, prop their feet up, give them a little fluids, make them feel better. But notice all the other things. Postural hypotension is the one that's actually by far the least serious. Every other thing listed in red potentially could kill you. So the reason I want to say that, not to scare runners, but when I'm covering a medical event running and I see someone go down, I want to let you know I'm not just thinking, oh, they're just dehydrated. I'm thinking, oh crap, I hope they don't have heat stroke. Where's my rectal probe? Do I have a tub I can where's my how can I check their sodium? Oh, this is not good. There's no way to check their sodium. Are they diabetic? Do we have any way to check their sugars? So a little scary for me sometimes, but again, you can even have a heart attack. How many people do you hear that die of heart attacks with major marathons? Boston, Chicago, you fill the blank, right? Every year it will happen. So does running help prevent coronary artery disease? Yes, I'm not talking about it does. So, but even though running helps prevent some of those things, unfortunately we still can have coronary artery disease and we can still die. But I still want you to run because I think your chances of living longer will be better if you run. That's good. Just don't die. But the big thing I wanted to emphasize is if you see someone not acting quite right, or maybe they're collapsed, the first thing is most likely they're dehydrated, most likely they're fatigued, and they probably need some fuel, right? They need some calories. But as a runner, I want you to think, is there any chance something else scary could go on? Any of those things in red that your doctor was talking about? That's all I want you to remember is not everything is just dehydration and fatigue. So that's my main take-home point about all those scary things. It's up to me to try to remember the other stuff. You don't have to remember all that. So exercise-associated hyponatremia. This is totally different than, let's say, maybe the schizophrenic patient I took care of in the hospital that loved to drink water. And they would drink 5 gallons of water a day. Polygenic polydipsia, really, really unusual stuff. So, and their sodium would be diluted. So this is different when you exercise. So how would you exercise? Lower your sodium. So sweating is part of it. In fact, we thought for a long time, okay, maybe you sweat off more water than you do salt. But we found it's actually more complicated than that. Part of it is, I'll put here, probably the most important thing is for hyponatremia related to exercise, people just drink too much water. That's probably the number one thing. People, and it sounds goofy, because we've been taught for a long time, right? Drink, 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 drink. But we found we probably swung the pendulum way too far the other direction. And now we stop off at every water stop along the way, and then we're just chowing down drinking. And before we know it, we've had 4 liters of fluids for a 10K. That's a little much. So, but we're also learning it's a little more complicated than that as well. And you don't need to know this, but there's this one hormone called ADH, this anti-diuretic hormone. Our body will secrete that in an attempt to reabsorb fluid. For some reason, we don't understand why, and some runners, they will excrete too much of that hormone, and that makes it worse. And that works out, so you just start retaining more and more fluid. We don't know why. And we think, I just read in the British Journal of British Journal of Sports Medicine 2 months ago, I think, kind of the world authority on hyponatremia was saying maybe there's even up to 15% of people that have excessive ADH secretion, but not everyone runs. And those that do run, not everyone will develop symptoms with it. It's maybe not that bad enough, right? So, someone that has hyponatremia, they too will be confused. They can be lethargic, they can be off the rocker, they can be walking kind of tipsy and intoxicated as well. So when I see someone coming into the medical tent and they seem really disoriented, probably the two things on the top of my list, emergencies are A, what's their temperature, and B, can I check their sodium and their sugar? And then, what's their blood pressure, etc.
What about throwing up?
Throwing up?
Yes.
Contributing to that? Or
Part of it too?
They often will be nauseous and feel like garbage. Throwing up won't cause that, but you definitely will
you
feel.
can't drink anymore because you're throwing up.
Mhm.
It's just a mixture of everything. You can't get any more fluids in because you're throwing up so much. So is that part of this here?
If someone is probably a little bit different, if they're that nauseous, and we'll talk a little bit about some GI distress that people have running. If they're that nauseous, it's probably not from over drinking because they haven't been able to drink in enough to make them sick. Although there are times runners can drink too much and you feel like garbage, right? But chances are probably not. One of our big questions is, what type of runner will get this? What type of runner is affected by a low sodium? Isn't that interesting? I did not come up with these three. So this is not me, I promise. I'm not a gender bias. But they say it's typically the slow beginning female runner. Sorry. So you could argue it's me.
Yeah, well, you're not
What they think is part of maybe with the slow and the novice is maybe they don't quite understand their appropriate fluid balance and fluid needs and fluid loss. But also, they're running slower and they tend to stop longer at every water stop, and they just sit and kick back. They drink in. Instead of just kind of running and splashing a little squid, they're taking down all fluid. I don't know female. Female might be associated with that ADH hormone, possibly. Maybe there's a higher level. We're not sure. So not to sound sexist, but maybe caution to some females who maybe are maybe more novice long distance runners and a little slower. Just be careful. I probably would be a little more careful than the average person to not drink too much. They'll still drink, please. Now, so that brings me to the next point. Now that I've scared you half to death about drinking too much water, I hope I didn't. How much water should you drink during a race then?
8 ounces per 20 minutes, is it?
There's a lot of formulas. Has anyone heard of any other formulas?
Drink
Drink So, as strange as it sounds, the world-leading authorities on this condition say, how much should you drink? Well, drink when you're thirsty. Isn't that weird? We've kind of gone full. I'm going to give you a gold star. So, that was weird. Because you tend to hear of two ends of the spectrum. We've always, well, not always, there's some people that say the more you drink, the better. Drink everything in sight. And there's others that have gone on the flip side and said, try to totally restrict your fluid intake. A, because it's a sign of weakness, and B, you can actually perform better if you're dehydrated. So I don't agree with either of those. So I think moderation is somewhere in the middle. So I'm going to go back here. Just realize that, first bullet, everybody's water, food, and salt requirements are different, not a one-size-fits-all. Someone might need 2 liters, another person might only need 1 liter, someone else might need 3 or 4, right? So just because your friend is drinking 3 liters does not mean, oh man, they've had so much, I should probably keep up with them. I would not fall into that trap. And also, Would your fluid requirements differ if you're running the Lost Soul and it's 34 degrees out compared to your Grand Moonlight run and it's 2 below? You bet, huge difference, right? What if you're running on a flat paved surface versus the coulees? Would your fluid losses differ? You betcha, right? And I think you just need to be aware that it's not just a cookie cutter approach. And so listen to your body, listen to your thirst, I think is really important. A couple goofy things. They say sweat rate is important. They've done lots of studies. Some people will sweat only 500 mLs an hour. Some people go all the way up to 5 liters an hour. That's one wet. I used to play racquetball with a guy that I'm pretty sure he used to sweat 5 liters an hour. So I think you guys weigh people, don't you, periodically? Is that right?
Yeah.
I think that's fantastic. And it gives us an idea. It's not perfect, but it gives us a pretty good idea if we weigh before a race or during and after, what are our fluid losses during a race, and then we can kind of replace accordingly. In sports medicine, one real simple calculation is for every pound you lose, you can replace with about 16 ounces of fluid. So, for example, let's say if a patient lost 4 pounds during exercise, they should replace with about 64 ounces. So, yes?
Is that replacement like post-exercise or during?
Both. So, it depends, let's say, when you weigh yourself. Let's say if you race at the beginning of the race, and then maybe 2 hours in the run, you realize you've already lost 3 pounds. Very appropriate to slowly replace those needs and make sure those needs are being met. Now, you don't have to replace it exactly. Your weight does not have to be exactly the same. Some people can lose 4 pounds at the end of a race, and their body does fine, no problems. Others really feel it. Others are really dehydrated and fatigued, and may not feel well. But again, as much as I've tried to scare you about drinking too much water, generally, people don't drink enough, generally. So just be aware of that. I'm sorry, I hope I don't try to scare you half to death, that you're never going to look at a salt shaker again. But one of my favorite topics, I'm not going to ask who. So yeah, don't put your tags there. That would be #1 mistake. Does anybody know who this is? Yeah, so The Office, right? So has anyone ever seen this episode of The Office? Absolutely hilarious. The Run for Rabies, perhaps one of the funniest episodes of The Office. So you can YouTube it, and they'll show you like this 3-minute clip of Run for Rabies, and I laugh. I think it's kind of funny. Maybe it's inappropriate. So this is, I'm kind of getting ready for the big race. I think it was like a 5K. So he's taking some nipple precautions. So his homemade nipple shields. And I was excited to see when I stopped by Runner's World, they have some products. They carry, I think it was the nip guards that I saw there. But, I remember the very first marathon that I took care of, one guy was kind of overheated. His temperature is about 104, which is about the bottom criteria for heat stroke. And so we put a temperature probe in, started the ice packing, removed his shirt. Like, what did he do with his nipples? So it was a few years ago, and I'd never seen that before. That was quite an introduction to, yeah. So there's a lot of different ways to protect yourself. Tape, obviously. Here's another unpleasant. This guy has a few pictures on the internet, and every single picture of this gentleman on the internet, there's about 20 bystanders glaring at him in disbelief, including these.
He looks like he's not too
More than one occasion.
I think it's the same race, because he's wearing the same outfit, it's about the same distribution. So that brings us to GI distress. So people can get exercise associated or exercise with GI distress. Has anyone ever called it the gingerbread? I had never heard of it. Is that common? I don't know.
That's awesome.
Is that something on the DL? I've never heard of it. That I laughed about as much as I did when I saw the blood eagles picture. So, but runner's trots, okay, so that's a pretty common term for runner's diarrhea. But what's very common is when people exercise long distances, all of a sudden they feel cramping, nausea. Does anyone get that cramping or nausea? I won't go beyond that, but so pretty common, right? It's very common. They say maybe 30–50% of runners. It's kind of quite a bit. Some people get to the point where they throw up. Others will actually have diarrhea. And so people say, well, why in the world does that happen? Again, they're not exactly sure, but probably a lot is we get really nervous when we run. We get a lot of pre-race jitters, anxiety, and stress. But also they think maybe that repetitive pounding, running and running and running, your bowel, kind of like your bladder, well, your bowel will just kind of flap and keep getting inflamed and irritated. And now that inflammation can maybe cause some tiny tears and you can bleed. And that bleeding and inflammation all of a sudden can be cramping and can actually stimulate your bowels and be a laxative. And then also, when you're running, again, your body's going to shunt your blood from your guts, away from your guts, to your legs, basically, where your body really needs it. So that ischemia can also cause the inflammation there. And I've seen some people take notes, which is great. If anybody wants, I can also email this to you, if anyone's interested. So I probably should have said that half an hour ago, sorry. Because we're getting writer's cramp. Oh, the other thing is diet. Actually, diet for some people can be huge. I listed a few things up here. Has anyone here found real certain things in their diet that can really flare this up? Anyone care to share? Any?
Fiber. Dairy.
Yep, dairy. Very common. Yep. Any others?
Cut out the fiber.
Pardon?
Less fiber.
Fiber, dairy, grease, those are all very, very common. Fuddruckers the night before the run. Wouldn't recommend. Yeah. So I think with your training, as you start doing some long runs, it's a good idea to see, are you picking up maybe with the food diary, something that's really triggering symptoms? Maybe you find, wow, I'm eating a lot of fruit and I feel really healthy until I go for my run and I feel like garbage. And that potentially could be triggered. And it's not that you need to eliminate that completely from your diet, but maybe the first 24 hours before you run is maybe not a good idea. I'm kidding. So it depends. I really would not recommend wearing those when you run. But the chafing. So I don't have a full lecture on anti-inflammatory medicines, but basically what we're learning is ibuprofen, Advil, naproxen, all these anti-inflammatory medicines, they're actually a lot more harmful than we used to think. We used to think, just take it before a race, after a race, all the time, I'll be fine. Just suck it up, princess, and I'll be okay, right? We're finding they're pretty harmful, we know, for heart, but also for kidneys, especially in long-distance runs, can be really harmful for kidneys. A little here and there is probably okay, but if you're taking that long-term, not good, and that can even aggravate this exercise and do some GI stuff. Has anyone ever taken Imodium pre-race?
I tried it once,
Yeah.
but I didn't get any.
I think it'll be hit and miss. I think if you know that you are prone to this, and you've got a big race coming up, I think it's fine if you want to pre-medicate. You can take it a few hours before the race, I think it's fine. Usually they'll say start with 2 pills, and let's say during the race if you're really starting to get loose bowels, you can take another one as well, and that's okay. You just have, I would recommend, I wouldn't do this all the time, but if you know you have a big race and you really don't want to miss the race, and you potentially could not finish because of this, it's very safe to do. I think we pretty much, and then staying hydrated. I didn't talk too much about that, but hydration for this actually is helpful because becoming dehydrated can aggravate maybe some underlying food triggers as well. I wrote down there in that 5th bullet, don't eat immediately prior to a race. I put about 2 hours. It really varies. Some people can eat a half hour before a race and they're fine. Some people have to wait 2–3 hours. But I'd say 2 hours is very average to give your time, body to digest. And kind of, so your body doesn't have to shunt your blood to the gut, so you can then start working towards your muscles. It was suggested maybe I discuss this a little bit. No one does not like to, no one wants to get a DNF, especially you've trained so hard. It's a fun race, maybe your ego's at stake a little bit, right? Maybe you've paid a lot of money, I'm kind of cheap, so I'm pretty upset about that. So when do you throw in the towel for the race? Any thoughts here maybe from the audience when or this time just a bag. What's that?
I said, Larry, what's your answer?
Oh, he says never. Yep. I won't ask anybody who's
I
abandoned
had
the
to
race.
quit because I lost 7 pounds.
7's a lot.
I had no choice. Yeah, I was throwing up by then, and I couldn't even get water down.
Wow. So that's a time where it sure would be handy to get IV fluids. You could
They
get,
didn't have those.
yeah, so if they were available, you could get 1 or 2 liters of IV fluids, and within about 45 minutes, you'd feel almost like a new person. You would feel
Yeah, I was starting to
significantly.
feel pretty good, but they
Yeah.
said, no, you didn't gain the pounds back. So
Yeah.
you're-
So like really big races, I was talking with the race director for the Ironman Hawaii in Kona. He's the director, and obviously they would first try oral fluids. If that didn't work, they were very quick to use an IV fluid.
Yeah.
And as long as people were holding things down, felt okay, right back out to the race. But it's not uncommon to put 1, 2 liters of fluid to people. Now I'm not saying I have to find where I'm going to get the fluid from first, but
Last year when I did the 50K, I was throwing up at the end, and they gave me the fluid. Within an hour, I was feeling wonderful. And the next day, I didn't even have any aches or pains. I didn't even feel like I had run.
Could have said it.
So I think it's a deal. There's some people
Yeah.
will, after they've done the long death race or whatever,
Yeah.
they'll go straight to emerge to get the fluid in them right away because the recovery is
Yeah.
so fast.
recovery is much, much faster.
Very good.
And it's not just upset stomach and throwing up.
It doesn't even hurt to go up and down the steps.
Yeah.
That's what's so funny.
I might actually start bringing some IV fluids to the race and like charge $20 a pop. Make a lot of money.
Better than the beer.
It's been great, yeah.
Portables in here.
Yeah.
So when I see an injury in someone, I always think, okay, A, what's going on? What's the nature of the injury? What's going on? And then B, how serious is this? And is this something that's, am I actually causing harm? And could this potentially be irreversible? So those are things I ask myself. I'll be honest, covering long distance races, I'm trying to think. I've covered an ultra down in Phoenix before. That doesn't really count because I was a medical student, didn't know what I was doing. I've covered marathons, but I would say once you get to the ultra, it's kind of a different breed. And most people honestly will say, Doc, get out of my way. Get out of my way, don't you dare touch me and don't you dare stop me from finishing this race. We're like, all right, I'll watch you.
Just the IV bed on
See?
the pole and it's around one.
Yeah.
My partner.
And so I actually take that into consideration. I think you have to think of the athlete's needs. What are their goals, their motivation, what's their ambitions, what's their race that they're involved in, right? That actually is important to me as well. You can't treat every person the same. And so running the Lost Soul is probably going to be different than if you're running the Ladies Fest. Not that there's anything wrong with either one, right? But it's, especially for men.
I really can't.
But I recognize if you're running the Lost Soul, you're probably really, really determined it's going to be really hard to slow you down. And so I might be more likely to let you go longer and have just a good discussion than I would maybe if you're doing a shorter race. So, in fact, there was just a quick story. Oh, I'm sorry, I'm really long-winded. So I was at a sports medicine conference about 2 months ago, and there was a physician who is an ultra-marathon runner as well. He's about 60 years old, has rheumatoid arthritis. Yeah, and he's a runner. That sounds like a great idea. And so he was running Leadville, Colorado, and difficult race. And he had heel pain, I think, before the race, and it sure got a lot worse. And he ran on it. I think that's 100K. Is that 100 mile? Is it 100 mile? Okay. And long story short, he was hobbling. He was in a world of hurt. And he missed the time cutoff by, I think, 30 minutes. His first time he ran that. And he found that it wasn't just plantar fasciitis that he had. He had a stress fracture of his calcaneus. So it pays when you can order your own bone scan. So, or your MRI. But again, he was one, I am sure the docs probably said, hey, Dr. Hill, I don't know, you look like you're pretty sore. Do you want to just kind of throw in the towel maybe? No, I refuse. Okay. You might have this. Do the best you can. So, growing up, if we can replace their fluids, go out and run. Maybe we can give you some gravel or some other medicine. So, I would treat that much differently than this. There's a good chance that person will not be finished the race, even if he wanted to. This person is probably dehydrated, cramping, and insufficient fuel intake as well. So I would treat those differently from a physician perspective. Some people, they'll have achy joints. I mean, you're going to have some achy joints if you run a long distance. You may even have stress fractures, and depending on the nature of the stress fracture, the location, I might be more likely to say, all right, if you want to keep running on this, you might have a stress fracture. Here's my card, come and see me when you're done with the race. Not to be, but I mean, seriously, I would say, hey, if you want to finish, if you look at a certain, if I'm really suspicious of a stress fracture in the hip, I'd say, I really think you should stop, because you might need surgery if you keep pushing this, and I would not recommend that. So I'm actually almost done. You guys, I think most people stayed awake. I appreciate it. So I have a couple more just kind of conclusion slides. I call them nuggets. So here's your ultra marathon running injury nuggets. So the first one is take care of your feet. When it comes to training, it's not really a one size fits all. It's really personalized, isn't it? It's individualized. When to drink to thirst. Listen to your body. Learn your food triggers before race day, preferably. I think know your medical resources. Most people who are triathletes or regular runners, long distance runners, they usually have kind of like their physio on speed dial or their massage therapist on speed dial, right? I think it's good to know this is not intended to be a plug for me, although I am a sports medicine physician. I don't work here, but there are 2 sports medicine physicians that work part-time here at the university. So Joel Weaver and Martine Frostad. So it's nice to know if your injury maybe isn't responding as you anticipate, or physio is finding, gosh, you should be getting better with this. Your shin splints, why aren't you turning the corner? It's maybe not a bad idea to see someone who has a little more expertise in that area too. As we mentioned, for fluid loss, one general equation is for every pound lost, roughly replaced with 16 ounces of water or fluids. Remember that some collapsed athletes may not be just dehydrated. They could actually be really, really sick, potentially critically. The treatment for heat stroke, the big tub of ice water, rapid ice water immersion. If you have blood in your urine for more than 2 or 3 days, I'd see a doctor. And then, yeah, don't be the one with blood in your urine. I just have a bunch of references. So again, if I send this out, if anyone wants, you'll have some references on here. Yes?
I just have a question. Some people are getting into the beer drinking, even at some of the aid stations. What's your thoughts on that with alcohol?
So I haven't seen any studies on that. I'm aware that people will do that. I honestly don't know how helpful that is compared to other electrolyte drinks and fluid. I'm maybe a little reluctant to encourage that in case, let's say there's heat or sugar or sodium issues, and someone has a little too much to drink. Are they a little bit off the rocker because they've been kicking back the O'Douls? Probably isn't that hard, but or if they're having some other issues. But honestly, I haven't seen any research that's looked at that. So I'm sorry I don't have a great answer. No, that's a great question. That's good. So maybe at the end of the race, do you have another question back here?
Yeah, I'm just wondering about that ADH hormone. Would that, can you ask for that just with a regular blood test? Or like how would you know?
We don't know.
Like a high percentage of people that you said didn't finding had it?
We don't have a great way to really test that. And so a lot of it probably is just kind of listening to how you respond to your sweat rate, your fluid losses, and your water needs. But honestly, we don't have a great way to test what is our ADH level, because you can have a baseline ADH level, which may be completely meaningless and totally unrelated to what it is when you've run 50K. And so unfortunately, there's not a great way to test that they found so far. Yes?
Is it safe to get cortisone shots like every week?
Cortisone?
Yeah, it's safe to get those.
So I use cortisone in my office. I actually use a lot less cortisone now than I did 5 years ago. We have decades of research that shows cortisone is actually really harmful to tendons and ligaments. Cortisone is used more out of tradition. It's just, I don't know, they've done it for a long time. This surgeon did it, so I'm going to keep doing it, so we'll just keep getting cortisone. Like I said, I do use it. For the feet, I do a lot of injections in my office, and some people in this room don't like me because I've come at them with needles. But it's quite uncommon for me to do cortisone in the feet. For example, plantar fascia or an Achilles, in the last 3 years, I probably injected maybe 2 plantar fascia with cortisone in the last 3 years. And I've done thousands of injections. And Achilles, I think I've done 1 in the last 3 years. So very uncommon, because there's such a high risk of tendon injury, tendon rupture with that. I can go on about cortisone, but there is, sometimes there are appropriate times, but if I have a long distance runner with foot problems, I'm really reluctant to inject cortisone for fear of actually doing more harm than good. They might actually feel really good for a few weeks or even a month or 2, and then they'll be right back to where they're at before, and potentially an increased risk of injury on race day. Any other questions? Yes?
With stress fractures, how long do you have to usually immobilize for recovery?
Great question. It totally varies on the type of stress fracture, how long they've been symptomatic, the extent of it. A general rule of thumb, most stress fractures you're looking at 4 to 6 weeks. Most fractures anywhere, they'll put someone in a cast for about 4 weeks. That's a very round number. So let's say that foot that we saw, that foot, I would probably put someone in one of those air cast walking boots for about 4 to 6 weeks on average. Know that with a stress fracture, the more you stay off of it, the better chance it has to heal. So I have a lady I'm treating right now that has a stress fracture in her foot. She went hiking up in Waterton twice last week with her boot on. I think it's okay, but I also know she probably would heal a little faster if she didn't do that too. But because she felt fine, she said she didn't have any pain whatsoever. I'm like, okay, you can hike on it. But just know you might be delaying your healing a little bit with that. Any other questions?
What's your opinion on caffeine?
Caffeine for performance or for?
During, before, after, just in general?
So I think caffeine in moderation for performance can be helpful for some people. For some people, it can be a diuretic and can actually aggravate some of their GI issues and can actually lead to a lot of cramping and diarrhea. And so if you've had some caffeine, you've run with that before, you seem to do okay, I think that's fine. But come race day, if you're just looking for a pick-me-up and you want to go grab some maybe 5-hour energy or jolt, I would not recommend that. I would not experiment with that. Yes, that's great questions. Anything else? These are my 3 kids a long time ago. My oldest is actually 12 and 9 and 5. Thank you guys. You guys have been wonderful. Thank you very much for your time.
Thank you, Dr. Galbraith. That was a great presentation, and I think we all learned a lot. You're okay to stick around for a few minutes if people have questions? Okay. Yeah, feel free to come pick his brain if you want. If you have some questions you wanted to ask one-on-one.